For a while, the obvious way to attack cancer has been directly at the cancer cell. So, for instance, chemotherapy damages and kills these rapidly dividing cells. Later on, targeted drugs began blocking specific receptors and enzymes that cancer cells depended on. And indeed, antibodies such as trastuzumab or rituximab show that even a molecule sitting on the surface of a tumor cell could become a therapeutic target. But there was another way to think about cancer, because a tumor is not an isolated ball of malignant cells growing by itself, okay? Because it lives in neighborhood, right? A microenvironment, and there are immune cells around this tumor mass. There are fibroblasts, extracellular matrix, blood vessels, oxygen gradients, and growth factors, right? So signals moving back and forth between malignant cells and normal cells. And once a tumor grows beyond a very small size, it runs into a surprisingly basic engineering problem, okay? Because then you start thinking of how do you keep all of those cells supplied with oxygen and nutrients? Because diffusion can really only carry oxygen so far. So as parts of the growing tumor become poorly oxygenated, the tumor can begin pushing the surrounding environment toward the formation of new blood vessels. And that process is called angiogenesis. And one of its most important signals is vascular endothelial growth factor, particularly VEGF-A, right? Because there are various isoforms, VEGF-A, VEGF-B, and so on. Okay, and this concept of angiogenesis gave researchers a completely different therapeutic idea, because instead of only asking what we could attack on the cancer cell directly, we now could also ask the question of what the cancer is asking the rest of the body to provide, right? And the answer in this case was blood vessels. And that is where bevacizumab became popular. Okay, originally marketed as Avastin, this is a recombinant humanized monoclonal antibody that binds VEGF-A. And rather than attaching directly to the cancer cell, bevacizumab binds this soluble growth factor that the tumor entering tissues can use to stimulate blood vessel growth. And let me just make this point before we move on, that cancer therapy is not the only indication for this drug, right? And diseases with neovascularization as a major mechanism could also benefit from it. And we'll see that later on down the line. And one of those, of course, is the neovascular age-related macular degeneration, an ophthalmic indication. And again, I'll allude to this again into the discussion today. Bevacizumab received its first FDA approval in February 2004 for metastatic colorectal cancer in combination with cell cycle inhibitors like a fluorouracil-based chemotherapy. It was the first anti-angiogenic monoclonal antibody approved clinically as a useful strategy in oncology. Before proceeding further, let me take you down a bit of a historical path here, all right? Because decades before bevacizumab was approved and before VEGF had even been identified, Dr. Judah Folkman began arguing that blood vessels around a tumor might be just as important as the tumor cells themselves. Okay, and he combined data from his work with data from other scientists and made a big proposal, okay, that continued tumor growth was angiogenesis dependent. A tumor might begin growing without its own vascular network, but beyond a certain point, then continued expansion would depend on its ability to recruit new blood vessels. And that led to a provocative idea. Okay? Because if a tumor depended on angiogenesis, perhaps then angiogenesis itself could become a treatment target. At the time, this was far from conventional thinking, and this was in the 60s and 70s. And at the time, cancer therapy was focused overwhelmingly on destroying malignant cells. Yeah, and so essentially, he was suggesting that therapy might not always need to eradicate every malignant cell directly, but perhaps cancer could also be controlled by depriving it of one of the biological systems it needed for continued expansion. But of course, always a hypothesis like that needed experimental evidence, right? So then came one of the most elegant demonstrations a few years later. In 1974, Folkman and colleagues described an experimental model using the rabbit cornea. Okay. The cornea is particularly useful for studying angiogenesis because it is normally transparent and contains no blood vessels. So you can actually see blood vessels growing through the corneal tissue as angiogenesis is being stimulated. And the cornea gives you an almost empty biological canvas to work with. Okay. And the researchers implanted tiny tumor fragments into the cornea some distance away from the existing blood vessels at the edge, right, the limbus, okay, the limbal plexus. And then they watched. At first, there were no vessels around the tumor, but after a period of time, new capillaries began sprouting from the vascularized edge of the cornea. Okay. They grew across the tissue that normally contain no blood vessels, right? The cornea is avascular. Okay. Until the blood vessels grew towards the tumor. Okay. The tumor was somehow sending a signal. Interesting. Okay. A signal so strong enough to recruit blood vessels from that distance. And because the cornea was transparent, again, the researchers could actually watch the process happen, and that was enormously useful. So then that angiogenesis now was no longer sort of something that scientists could only infer by looking at a tumor after it had grown. They could actually see it developing, okay, and they could measure how quickly vessels appeared and how far they've traveled and how strongly the tumor is stimulating them as well, and then eventually whether an experimental treatment could stop them. That corneal model, together with other angiogenesis assays developed around the same period, gave researchers tools to begin dissecting the biology. And that means the question to address now was, what is the tumor releasing that makes these blood vessels grow? Okay, and that question would eventually lead researchers towards some of the major molecular drivers of angiogenesis, which I wouldn't go into now because it's going to be beyond the scope of this discussion. But of course, one of the most important was vascular endothelial growth factor, VEGF. Okay, and I'm going to use the next figure to explain the biology of this molecule as well as the mechanism of action of bevacizumab. Let's imagine a group of cells sitting some distance from the nearest functioning blood vessel. All right. At first, they may get enough oxygen simply by diffusion. But as the mass expands, cells further from the vessel receive less and less oxygen. Eventually, parts of the tumor become hypoxic, right? Low oxygen levels. And cells are very good at detecting oxygen levels, right? So if the oxygen is very low, they can detect it. And one of the major molecular responses involves proteins called hypoxia-inducible factors, or HIFs. When oxygen is low, HIF signaling can increase the expression of genes that help cells adapt to that environment. And one of the most important genes switched on by this response is VEGF, right? Vascular endothelial growth factor. And as I mentioned earlier on, VEGF is a family of related growth factors, right? But for bevacizumab, the important target is VEGF-A. VEGF-A can be released into the surrounding tissue where it interacts with receptors on endothelial cells, right, the cells lining our blood vessels. And there are two important receptors here, VEGF receptor 1 and VEGF receptor 2. And these are tyrosine kinase receptors, right? And VEGF receptor 2 is particularly important for many of the classic endothelial responses of VEGF-A. When VEGF-A activates these receptors, it triggers signaling inside endothelial cells. And that signaling can promote endothelial cell survival, proliferation, migration, the formation of new vascular structures, and of course, increased vascular permeability. In other words, it can make the blood vessels more leaky. And that makes sense when you think about normal tissue repair, right? If a tissue has been injured, you may want plasma proteins, immune components, and new vessels entering the area. Okay. But tumors, of course, can exploit that same biology. And tumor angiogenesis is not the same thing as building a perfectly, beautifully organized new vascular network, because it can be quite the opposite here, because tumor cells, tumor blood vessels are often abnormal. Right? They can be tortuous, dilated, poorly organized, structurally immature, and unusually permeable. Right? Blood flow through them can be irregular. Some of the areas receive relatively good perfusion, other areas can remain severely hypoxic. So strangely enough, a tumor can have lots of vessels and still contain areas that are starved of oxygen because perfusion is not uniform throughout the tumoral mass. And that can lead to a feed-forward cycle of events. Right? More hypoxia, more pro-angiogenic signaling, more abnormal vessels, more disorganized perfusion. Right? This is the biological environment that VEGF creates within the tumor. And bevacizumab interrupts one major part of that conversation. Okay, the drug binds VEGF-A before VEGF-A can activate its receptors on endothelial cells. That means VEGF-A has less opportunity to bind VEGF receptor 1 and VEGF receptor 2, and downstream VEGF signaling is then reduced or abolished. So, as simply as I can put it, the tumor and its surrounding cells produce VEGF-A. VEGF-A delivers a pro-angiogenic message to blood vessels. Bevacizumab catches VEGF-A before that message reaches the endothelial cell, and that not only starves the tumor, but it also effectively deprives the tumor of a pathway for distant metastasis. Now, let me just add here, there is also supporting evidence about the idea of vascular normalization, right, of bevacizumab here, because tumor vessels, like I mentioned, are chaotic and excessively permeable, which means that reducing VEGF-A signaling may make parts of that disorganized vascular network less abnormal, right, potentially reducing leakiness, and under some circumstances actually augmenting anti-tumor immunity, while also improving perfusion or delivery of other treatments, right, within a particular regimen. Now let's look at approved uses. Now again, just a note here that I'm making this video for educational purposes only. Right, prescription information can vary widely and are updated regularly. So for the most up-to-date review, please refer to your local guidelines. One of the major indications for bevacizumab remains metastatic colorectal cancer. And you remember that was the indication as well at the first FDA approval. It can be used with intravenous fluorouracil-based chemotherapy in first or second line treatments. And there are also specific second line combinations for patients whose disease has progressed after a first line regimen that already contained bevacizumab. It is, however, not indicated as adjuvant therapy for colon cancer. So assuming surgery has been done to remove a patient's tumor, adding bevacizumab to standard post-surgical chemotherapy will not prolong disease-free survival and may potentially be detrimental. For lung cancer indications, early experience identified a substantial risk of severe pulmonary bleeding in patients with squamous tumors given bevacizumab. Alright, so as a result, the drug now is only approved for first-line treatment of non-squamous, non-small cell lung cancer in combination with carboplatin and paclitaxel. Bevacizumab is also approved for recurrent glioblastoma in adults and metastatic renal cell carcinoma, where it is used with interferon alpha to sort of help augment anti-tumor immunity. For persistent, recurrent, or metastatic cervical cancer, it is used with specified chemotherapy combinations. In hepatocellular carcinoma, bevacizumab can be combined with the immune checkpoint inhibitor atezolizumab for patients with unresectable or metastatic disease who have not previously received systemic therapy. Atezolizumab targets immune suppression through the PD-L1 pathway, and bevacizumab targets VEGF-A and the vascular component. So one regimen is simultaneously influencing the immune system and the tumor vasculature. So it's quite an interesting pair here. We will tackle atezolizumab in more detail in a separate discussion. There is also a non-cancerous indication for bevacizumab in ophthalmology, and I alluded to this earlier on in the discussion, right? Because VEGF is not only important in cancer, it is also deeply involved in abnormal blood vessel growth and leakage inside the eye. So in diseases such as the neovascular or wet age-related macular degeneration, abnormal vessels can develop beneath the retina, and those vessels are fragile. You see, they leak fluid and blood, and that can damage the macula, the part of the eye responsible for detailed central vision. And VEGF-A is also involved in retinal vascular diseases associated with diabetes and retinal vein occlusion. And bevacizumab has been repurposed as an intravitreal injection for the treatment of these ocular indications. In fact, you may see it being used for conditions like neovascular glaucoma, corneal vascularization, pterygium, and even after trabeculectomy to prevent failure of the bleb, right, the fluid reservoir. Now, like several other major antibody drugs, bevacizumab also entered this growing biosimilar arena. Okay, a biosimilar is simply a biological medicine that has been shown to be highly similar to an existing product, right? So a reference drug, in this case, Avastin, and it's found that there is no clinically meaningful differences in safety or effectiveness between the biosimilar and then the original product, the original reference drug, Avastin. And some of the benefits of having biosimilars will include lower healthcare costs, increased market competition, which means patients and clinicians can now have options and easy access to these life-changing medicines without compromising disease outcomes and overall patient care. So there are multiple bevacizumab biosimilars in different parts of the world. So in practice, a patient receiving anti-VEGFA therapy may be receiving bevacizumab without the name Avastin appearing on the vial. Bevacizumab, as part of an oncology regimen, is given by intravenous infusion. That means treatment is usually delivered in the hospital center, cancer center, or infusion clinic, often on the same day as a chemotherapy or other systemic treatment it is being combined with. And we already mentioned a direct intravitreal injection into the eye, vitreous gel, by a specialist, of course. Let's discuss now the safety profile of bevacizumab. There is no doubt that VEGF is part of normal vascular biology because our bodily tissues require oxygen and nutrients supplied through blood that travel through blood vessels. And VEGF-A supports these normal vascular physiology. So things like endothelial cell survival, blood vessel maintenance, tissue repair, wound healing, kidney function, and reproductive biology. So when we interfere with VEGF as part of cancer treatment, we also indeed interfere with processes normal tissues would require. And that is where many of the drug's characteristic toxicities originate from. One of the most serious, of course, is gastrointestinal perforation. Now, this is uncommon, but it is potentially life-threatening and is indeed a surgical emergency. Patients can develop intra-abdominal infection, abscesses, sepsis, and as I mentioned before, they may require emergency surgery. Bevacizumab is also associated with fistula formation, and the classic definition of a fistula is that it is an abnormal connection between two epithelial lined surfaces or body spaces. And now, depending on where it develops, that could involve the bowel, the vaginal lining, bladder, airway, or other organs. These complications are especially important in certain clinical situations, including some patients with prior pelvic radiation, tumor involvement of the bowel, or the local risk factors. Then there is wound healing. If you cut or injure tissue, one of the things that tissue needs to repair itself is a functioning vascular response, right? So new vessels have to grow into healing tissue, and VEGF contributes to that process. So blocking VEGF can impair wound healing. This is why timing around surgery is taken so seriously. Just for instance, for elective major surgery, the US Prescribing Information instructs clinicians to withhold bevacizumab for at least 28 days beforehand, and it should not be administered for at least 28 days after major surgery and until the wound has adequately healed. Bleeding is another important risk and could range from minor nosebleeds or gingival bleed to serious or occasionally fatal hemorrhages in major organs. All right, for example, patients with advanced liver disease may have portal hypertension, right? And portal hypertension can produce enlarged veins, okay, varices, in particular in the esophagus and the stomach, right? And those veins can bleed catastrophically. So when bevacizumab is considered as part of the atezolizumab-bevacizumab combination for hepatocellular carcinoma, bleeding risk and varices deserve particular attention. The drug can also increase the risk of arterial thromboembolic events, and these include events such as myocardial infarction, stroke, transient ischemic attacks, and the risk can be particularly relevant in older patients and in people who already have cardiovascular risk factors or a previous arterial thrombotic event. Venous thromboembolism can also occur, so think of deep vein thrombosis and pulmonary embolism. And remember, cancer itself already increases the risk of thrombosis, right, because of increased hypercoagulability states. Hypertension is one of the characteristic effects of inhibiting VEGF signaling. Okay, blood pressure can rise during bevacizumab therapy, sometimes significantly, and if hypertension develops, it is treated. Okay, if it becomes severe and cannot be adequately controlled, then bevacizumab may need to be withheld. Okay. And if a patient develops hypertensive crisis or hypertensive encephalopathy, so-called PRES, posterior reversible encephalopathic syndrome, treatment is discontinued, right? No questions asked. Thankfully, as the name suggests, PRES usually resolves upon stopping the bevacizumab treatment. In the kidneys, VEGF signaling helps maintain the microvascular environment of glomerular filtration, and that environment can be disrupted with bevacizumab. Right? One clinical sign is proteinuria, okay, protein leaking into the urine. For many patients, this is mild, but significant proteinuria can occur, and rarely patients can develop the nephrotic syndrome. VEGF biology also reaches into reproductive medicine, and bevacizumab has been associated with ovarian failure. Okay, so for patients for whom future fertility matters, fertility counseling may need to happen before treatment begins. And bevacizumab can cause fatal harm because developing tissues require precisely controlled formation of new blood vessels. Okay, angiogenesis is fundamental to embryonic and fetal development. So pregnancy and contraception need to be discussed when relevant. Regarding drug interactions, you can kind of decipher these easily from the side effect profiles, right? So anticoagulants, antiplatelets because of the combined increased risk of bleeding, drugs with hypertension as their side effect, such as the small molecule receptor tyrosine kinase inhibitor sunitinib, right, which works by interfering VEGF signaling anyways. But of course, other VEGF or VEGF receptor inhibitors can be problems as well. And anti-drug antibodies occur with very low incidence in bevacizumab treatment, and this has been a consistent finding across several studies.